Welcome everyone. This is the track A for the Hack for the Future, track A, AI and the future of healthcare. The organizing team, the mentors, the judges, and all the participants are here for track A. We're very excited that this is the final stretch of this hackathon. I hope you all had fun. So now is the final pitch session. So we'd like to also thank all of our sponsors listed on the slide. This has been a hugely collaborative effort, and we're grateful for everyone's sponsorship and help. Couldn't have done it without you. So these are the final presentations. Track A, AI and the future of healthcare, had 3 different areas of focus: digital health, vaccines, pharmaceuticals, and population health, and research and innovation. Quite a broad set of topics, and we're excited to listen to the different teams' innovation pitches. We have an esteemed panel of judges today. In the health track, Jennifer Joe is the Chief Medical Officer of Biocognitive. Chris Kaiser is Amgen Professor of Biology, MIT. Luba Greenwood is Healthcare and Tech Investor Innovator at Harvard. Radhika Iyengar Immens is the author of Venture and Serial Entrepreneur. And Kate Murphy is a Healthcare Life Sciences Practice Leader at Accenture. And this is just a brief overview, and I'd like to open the floor to the judges to, if they have anything else they'd like to say in their introductions. So please, Jennifer.
Hi, everyone. Honored to be here. I know you guys have worked hard. Just really impressed with all your hard work and the fantastic group that's been gathered here to solve big problems. Great to be here.
Great. Welcome, Jennifer, and thank you. Chris?
Yeah, I'm happy to be here too. I'm really looking forward to hearing the presentations.
Wonderful. Luba, she's here already. Luba? Okay, we'll come back. Radhika?
Thanks. Really great to be here with everybody, and super excited to hear all of the great presentations on solving important issues in healthcare.
Wonderful. Kate?
Wonderful to be here. Thank you so much, everyone, for taking your time and inviting us as judges. Just want to say, please, be comfortable. We're here as coaches as well as judges, and we've all been in your shoes before. So we're really excited to hear what you have to say. And I can say personally, I've learned lots from these in the past, and I'm looking forward to learning from you today.
Wonderful. And is Luba, are you here? Do you want to introduce yourself?
Igor, looks like she is facing some connection issues. So
okay.
I think we can move on.
All right, if there's a chance later, a little pause, we can let her introduce. So the hackathon process, I'll let, so this is basically, you've been through this multiple times, right? The hackathon process is that on Friday night, you've pitched your preliminary ideas about the problems and solutions. You've then formed teams. This is the most impressive part to me, is that we've had a global participation from a variety of ethnicities and regions of the world, people that didn't know each other. Most people didn't know each other, and you've come together in collaborative ways, working well together to come up with innovative solutions for real world problems that the COVID-19 pandemic has created. And this has been really impressive. You've gotten feedback and mentorship from from mentors. You've iterated and improved your solutions based on their feedback. And here we are. These are the final pitches, and we really look forward. And now I'll turn it over to Martina to cover the judging criteria.
Hello. So we have 4 basic judging criteria on the next slide that you will be judged on. All of them have equal weight. It's impact, innovation, implementation, and presentation. In impact, we will be looking at the proposed solution. We'll be looking if it addresses the problems that are real world problems that can make a real impact. In innovation, we will be looking how novel is the idea? How does it compare to something that already exists? In both of these, we will also be looking at inclusiveness and diversity as a side criteria. Third is implementation. Are you communicating? How do you plan on execute your idea? Is this the right team to execute what you are suggesting? And the fourth one is presentation. How well is your team presenting the problem and the solution? All of these four criteria have an equal weight in evaluations. Next slide, please.
And one more thing to emphasize is that for impact and innovation, we judges will also consider inclusiveness and diversity of innovation and how innovative and how your solution addresses diversity and inclusion in terms of impact and innovation.
So here is the logistics of the final presentations. It will be actually somewhat similar to your practice pitches. You will have 3 minutes to present and 2 minutes for Q&A from judges. We will be measuring your 3 minutes. After 2 minutes, I will show you green. After 2.5, yellow. And after 3 minutes, red. And then we will move on Q&A. Also, we would like to let you know that this session is being recorded. Every slide will show which team is currently presenting and which team is next. The teams are presenting in random order, so everybody has the equal amount of time to prepare. We will be picking 3 winners per track by our wonderful judges. So let's move to the next slide. Once you will be up to speak, please raise your hands so we can help unmute you if you are having problems unmuting yourself. Next.
And as mentioned, you'll have 3 minutes to present, and then there are 2 minutes for questions and answers.
That's very correct. The first team is team 33, Carlsmed. Please raise your hand and unmute yourself.
And after that, it's going to be Vaxi Assist, team 7. So just please prepare your team.
Team 33, Carlsmed, are you ready?
Yes.
Wonderful. So you can start whenever you are ready.
Okay. Okay, here we go. Hello, everyone. My name is Yashar, and today I'm going to introduce you to CalosMed, AI solutions in telemedicine and beyond. Next.
So we want to apologize in advance. We had some issues with colors, so some of these backgrounds are not coming out as originals, but please get through that. Thanks.
I'm sorry, can we just fix it, or?
I'm sorry?
Can we fix it, or?
1 second.
Can we fix this, or it's going to be like this? Okay, I go through it. Can we just start from the beginning again?
Yes, I'll highlight it so it's easier to see.
We can try to highlight. I'm very sorry. We tried our best.
Okay, so here we go. Well, let me tell you a story first. Well, Dr. Jackson works at a telemedicine office. His workload has increased a lot ever since the pandemic has started, because the number of patients who are relying on telemedicine has increased a lot. A tedious task for Dr. Jackson is filling EHRs, electronic health records. In fact, it's such a tedious and frustrating task for Dr. Jackson that it can even contribute to he getting burnout. And we don't want Dr. Jackson to be a burnout physician. Next. Now enter AI. We're here to help out Dr. Jackson and his colleagues with the help of AI. You may ask how? Well, we're going to help him by automating the whole process in 4 simple steps. First of all, we're going to transcribe the conversation between him and his patient. And then we're going to extract the important parts from this. And then we've got the required EHR data using AI. And then Dr. Jackson has to read it once, and then he has to verify it and submit it. That easy. Next. Now, You may ask, what makes it different from similar solutions? Well, first of all, let me make it clear that privacy matters a lot to us. So we are actually not going to store any data. It's done real time and it's not going to be stored anywhere. About competition, well, no interaction with the system is required. It's all done by the system and just a simple confirmation does the whole thing. And about interoperability, well, you don't have to worry about it either because we're not going to reinvent the wheel about EHRs. We're going to build it up on tried and true EHR and medical AI solutions done before. Next. Now, let's get this into numbers. Physicians spend an average of 16 minutes and 14 seconds per encounter using EHRs. 50 to 80 million telehealth visits are projected for 2022. And the telehealth market is going to reach $3.5 billion in 2021. So we thought, based on our estimations, we're going to minimize the time that is spent on filling out EHRs. Therefore, now Dr. Jackson and his colleagues can pay more attention to their patients, and they've got much more time to spend with their patients. And actually, about the market and the money, well, $1 billion projected for a cost saving in 2022. Next.
You want me to skip the slide, or it's marked as not visible?
Yes, yes. And beyond. Well, first of all, we want to partner up with a telemedicine provider in this year. And in the following year, we're going to expand our solution scope. And then we're going to expand into a complete AI HIT solution. And then after that, we're going to integrate it with all major players in healthcare industry and health data providers. Next. We're going to revolutionize EHR in the long run. Are you ready? We are ready to. Done.
Okay, thank you. This is team of 33, Talismad, and now we will move into judges for their deliberation, or I mean for their questions and answers.
Okay.
So judges, do you have any questions?
Yeah, I have a question. So I understand the transcription part, but once you have a transcription, what does the AI actually intend to do? Like, what would that do for a doctor? Like, just give me a hands-on example.
Okay, well, that's a very good question. When the data is when we got the transcription, it's raw data, we have to prepare it more. And not all points in that data is going to be useful. With the help of state-of-art AI, we're going to evaluate the important parts and highlight the important parts which are usually useful for the physician and further use. And then the EHR is generated automatically. That's what we intend to do with that part.
So where is the time saving? Are you still proposing that physicians are putting this information in and then you're using AI on the back end, or are you somehow using a voice to text functionality into the EHR? I guess I'm confused on where the time savings is coming from here.
Well, actually, filling those EHR is a tedious task, and it's it's recently some studies have linked the EHR visibility with clinician burnout.
I don't doubt that. I absolutely hate doing that. So I'm on board with you on there. But where are you saving me time? How is it being filled out now?
Well, similar solutions are actually going to just help you with dictation. It's just a simple assistant. But this one gets you to do this totally automatically, and you're just kind of like a click away from confirming the whole thing.
So you're going to essentially take my Dragon technology, right? And then you're going to do some sort of NLP processing to fill in.
Yes, natural language processing algorithms. And actually, that's something that our AI specialist could actually explain more. I think he's here if you want.
I'm tracking you now, how you say you're going to do that. So you're going to take dictation software, and then you'll do the ability to do automatic filling in of basic click buttons, I would imagine, right?
Yeah. Can you hear me?
Yep.
Okay. Just to complete my teammate's point, we are using a query-based abstractive summarization method, which basically responds to queries about different topics and abstracts the text and picks out the important details relevant to the query. So it's a new AI method developed by researchers in Cornell University, and it's been used on different materials from scientific papers, but then it should be adapted to the transcription of dialogue, and we'll think it will work great in this scenario.
It will solve a real world problem, it means.
So why do you think this doesn't exist today?
Sorry, I didn't hear you.
So I agree on the pain point, right? We've had this for the last 10 years. Why do you think this hasn't existed today? What do you think the biggest pain point is you're going to have to solve in implementing this solution?
Well, you know, one of the key points that I think I made was about the burnout thing. And I think that basically telemedicine has had, you know, kind of a roller coaster way throughout these years. It's been sometimes used and it's been sometimes, you know, kind of forgotten. And that's why that it's not usually adopted all the time, and it hasn't really been used to improve it. You know, I think that's why they haven't really done this before. And there are also assistants which actually help doctors. In fact,
I'm sorry. Sorry to interrupt. What did you say hasn't been adopted? Sorry, I just didn't hear it, that part.
I wanted to say that because telemedicine is actually not a complete encounter with the patient, usually it's overlooked in the world of medicine. And sometimes, like this in pandemic, the problems of such technologies and such things are much more exposed. And now we aim to improve just one part of it and then expand it to more kind of a broad technology.
Igor and team, I think we have to move on.
Can I ask everyone, I'm trying to make the slides bigger. Is it better?
Yes, I think.
Okay, great. So thank you very much. Now is team 7, Vaxi Assist, and that after that is Health Connect. So. So team Vaxi Assist, please raise your hands.
Can we begin with the next slide, please? Yeah, perfect.
Go ahead. We can't hear you. If you can, but you can get started, please.
Okay, sorry. 9.6 million, the number of unvaccinated children in India, highest in the world. India loses $7.5 billion per year due to wastage of vaccines. The root cause for this is the lack of cold storage. Next, the key pain points we're focusing on are wastage of vaccines due to poorly equipped and expensive cold chain management and transport, failure to note the vaccine reconstitution time, and the lack of defrosting knowledge leading to shortage of viable vaccines. Next, we also conducted a survey with healthcare workers during the hackathon and found out that 60% of the healthcare centers are using a regular refrigerator for vaccine storage. Next, how do we ensure safe and secure delivery of vaccines from source to destination in India during and post-COVID times? Next, the solution to this problem is Vaxi Assist. Vaxi Assist enables real-time temperature and humidity logging, inventory management, and prediction of wastage and shortage of vaccines on regular intervals. Next, our solution consists of a portable vaccine carrier that maintains required temperature up to 16 hours and gives real-time data of temperature and humidity. It also maintains inventory by checking the lot number. Next, This carrier is connected to a free mobile app. We are leveraging artificial intelligence coupled with relevant data of vaccine inventory. Our algorithm is trained to predict the shortage and wastage of vaccines, and an alert is immediately sent to the manufacturer for upgrading or downgrading the production. It's an end-to-end solution, starting from the manufacturers to the public health centers and finally to the patients. Next, for the healthcare provider, we are offering a portable and affordable vaccine carrier with immediate alerting system, tracking the lot number and easy to use in low network settings. For manufacturers, we facilitate prior notification on the number of vaccines that are required, saving workforce, time, and reducing the wastage during transit. Next, we're empowering the healthcare providers with AI-enabled efficient technology, which lessens the healthcare burden and improves the outreach of vaccine delivery. Next, we're following a B2B2C business model and will gain revenue from selling the device to providers, revenue sharing model with vaccine manufacturers, and local health authorities. Next, this is our go-to-market strategy. We'll conduct the pilot study in April 2021 in Chennai, which is 2.1K primary and secondary vaccine delivery hospitals. Next, this is our timeline. Next, as you can see, Vaxi Assist is a portable and affordable and the only vaccine cold storage system that gives a predictive analysis of wastage and shortage of vaccines with an inbuilt alert alarming system, creating a safe and secure environment for saving vaccines. Next. This is our team. Thank you for listening to us.
So I have a question. I could ask a question.
Yes.
So great area of focus. This is a huge problem worldwide, not just in India. Very happy to hear that you're working on this. One question is, in regards to data, we know that there are many issues and not just solvable through AI. There are fundamental issues of data, particularly when you're talking about vaccine and inventory management and supply chains for vaccines, which is really the problem that you're addressing. I didn't really hear in your presentation how you are basically tracking the data, the traceability of data and the auditability of this data throughout the life across the supply chain. As we know, these are points of vulnerability in supply chains. There's no visibility from one supply chain way station, if you will, along that logistics chain or into inventory management. So the visibility is very, very low with given technologies that we have today. Plus, there is no shareability and auditability of that data across that entire chain. And this is one of the big issues that is present in the area that you're working in. So could you elaborate on that?
Yeah, I'm going to answer that question. Is it possible to go to the last slide of the appendix? The last slide of appendix? That's actually a very good question. And we did think about that.
Is it this one?
Slide. No, the one next. Yeah. So the one before that. So if you see, these are the wages areas starting from the manufacturer. I'm sorry, it's slide number 42. If you see, these are the areas starting from manufacturer, who's the supplier, to the end, the beneficiaries. These are multiple areas in which especially vaccines in India are going to be transmitted, right? So this is the transit areas. So we did look upon which areas our product can be used. From the manufacturer, there is tracking of vaccines through the box itself. So one of the important areas we're focusing on is cold storage facilities, especially for rural India, considering the fact that there are no facilities like the ice line storage facilities available in these rural and remote areas of the country. There is a need for a portable vaccine carrier to take to these specific places and maintain temperature logs. At the same time, get in touch with the manufacturer as soon as possible. Because in India, you need to place an order for vaccines at least 5 months prior, especially in rural areas. So this keeps a track of the number of vaccines which are stored in the carrier as well.
I understand that you're capturing the data. My question was more so, creating the audit trail of data, which means that you have to prevent tampering. One of the biggest issues in this is the tampering of data. People are manipulating the data and saying, yes, we maintained it at a particular temperature when it wasn't, and that's what's resulting in the lack of viability of these vaccines at endpoint. So my question is, how are you securing the auditability and the transparency and the accuracy of the data at the points that you're collecting this through your cold storage or other IoT devices or whatever you're going to bring in to secure?
Yeah, so
Right. That's
sorry
actually a very,
sorry
yeah.
for interruption. Yeah, I want to answer this question according to this, like for the security purpose of the data, like we will be using these real-time databases. They have a high security, like only administrator can access, like what kind of temperature these vaccines can be stored, and so there will be complete security in these databases in which we will be going to store the vaccines temperature.
Okay,
So one of the things we're focusing on is real-time temperature and humidity analysis. So that is the first part, or the first pronged approach for the solution, is real-time analysis of temperature and humidity. We were thinking of collaborating with public health centers. Now, public health centers in India are obviously under the municipal corporations or the district administration. So this application is going to be maintained by the health authorities out there. So the data protection and the data security aspects are going to be tracked with this.
So thanks for that response. Just since we're going to run out of time, just a quick mention, you're going to need to look at blockchain to secure the data. And so that's kind of what I'm leading to. I have extensive coverage in my book, by the way. You can check out my book. But there's an extensive coverage of that particular topic, because this is a very, very important topic, and it's going to be crucial to securing your supply chain and preventing tampering, even by administrators. So just saying. But thank you very much. Really.
Thank you.
Wonderful, thank you. We are out of time. A little bit ago, let's move on to the next team. This team was Vaxi Assist 007. Now we are on to team 43, Health Connect, and coming up, team 05, eCare benefits. Also, a note for judges and everybody, we keep posting the name of the teams in the chat, so you always know who is presenting. Team 43, you can unmute yourself and you are welcome to start whenever ready.
Hi, can you hear me?
Yes, you're audible.
Okay, that's great. Can I get started now?
Yes, go ahead.
All right. So welcome all. We are Health Connect, where a fall is not an option. Next. Next. So, sorry, go back. So here is Anne, a 73-year-old. She lives in an independent living facility and has limited mobility. She has experienced several falls in the past year and had to undergo multiple surgeries. And just one hip replacement cost her about $32,000. She's worried about falling and getting injured again. Next. So what if there was a way to predict her risk of falling to prevent falls in the future? So here's where we come in. We are Health Connect, a smart install using sensors to monitor your walking over time and detect trends of unstable gait with respect to your cadence, stride length, and swing velocity using an AI algorithm. Our system will notify your caretaker by connecting to their mobile app. Next. So how does this work? So say this patient is Anne. Then her gait data will be collected from the smart insole, which will then be used to track her walking pattern over time. The data will then be sent to a cloud platform, and then it will be fed into a predictive AI algorithm, which will be deployed in her caretaker's app. This will then look for trends of unstable gait, and if a certain threshold of instability is passed, we will notify her caretaker to take preventative actions, such as recommending her a walker or seeking a healthcare professional's advice. So in that way, we prevent falls from happening in the first place. Next. So here is the interface of the app which the caretaker will use, and this is where they will input the patient's medication and history. And the app will also show the patient's walking patterns over time and provide a risk fall assessment. Next. So here are some of the competitors we have. So compared to other approaches, our solution uses an AI algorithm to predict the risk of fall in the future and sends that information to the caretaker. And we estimate that the cost of fabrication is about $100 to $200, as you can see here. Next. So why is there a need for our solution? Because over 800,000 patients are hospitalized because of a fall injury. So if we reduce one fall, we will reduce the burden on the caretakers and reduce the associated costs for both the patient and the insurance companies. Next. So here you can see our customer segments, which will include independent living facilities and family members who take care of the patient. And here you can also see our market plan and our overall revenue model for the app. Next. So currently Health Connect is in the concept phase, which aims to test a prototype by recruiting senior patients. However, we'd like to move on to the beta testing. We'll utilize the prize money to consult with experts. And after the validation of our product, we'll move on to the marketing and the deployment phase, as you can see here. Next. So this is the diverse team of Health Connect, and we hope that with our solution, we will reduce the number of falls in the future and their associated costs. Thank you.
Wonderful, thank you very much. And again, this was the team A43 Health Connect. Now let's move to the judges' questions and answers.
Hi, thank you. Thanks for presentation. What is your go-to-market strategy? Are you going to Medicare Advantage plans or employers, Medicare? Or are you just going straight to direct to patients or through providers? What's your go-to-market strategy here?
Sure. So first we'll start off with health systems. So we'll get in contact with, independent living facilities where their patients are living alone. And we'll also reach out to, nursing homes where there's a lot of, residents that live there. And so we'll start off with them and we recruit the senior patients there. And we'll also try to, use senior patients from family members, close friends and family members. So we'll start off with that. And after the deployment of our solution and its validation, we'll start implementing it with these patients. And obviously, we're going to be collaborating with Medicare insurance companies, to get to get information from them and use EHR integration data with that as well.
Hi.
Wonderful. Does another judge have a question?
Yes, good presentation. I have a question in regards to your solution. Could you go back to your solution slide, please?
Sure. I think it's on the third slide. Yeah, there we go.
So can you tell me precisely how you're collecting the, what are you wearing something in the shoe basically then, and you're collecting the data? Is that what you're talking about?
Yes.
And
so basically,
what data are you actually collecting? Can you go over that?
Yeah, sure. So basically this insole is going to be implemented with an inertial sensor. So these sensors can be an accelerometer and they can be like a piezoelectric sensor and all of these sensors. So basically these sensors are going to be integrated in this and they're going to be integrated into this insole, and this insole will fit into the senior patient's whatever they wear, like their shoe, for example. And so that sensor is going to collect their data, and this data that gets collected from the sensor will be integrated into a database in a cloud platform. And that cloud platform database is going to have all the good data. This data will then will run a predictive model, a deep learning or a machine learning algorithm. And then with that, if a certain threshold of instability is passed, the patient's data is gathered over a couple of weeks, and using their data profile. So if a certain instability threshold is passed, this will connect to their caretaker, whether it's in the nursing home, or their family member who takes care of the patient, connect to their app, and then they can see the working patterns over time. And then it will tell them that this patient needs to consult with a health professional. Their medication they're taking might be the result.
I get that. Sorry, in the interest of time, I just wanted to cut to the chase on a question. So this is an area that I've actually worked a lot on, and while I appreciate the problem you're trying to solve and the solution that you're coming up with in terms of an insole into a shoe, in actual field implementation, it's a little bit more complex than just having a shoe on, because a lot of patients or a lot of senior citizens, for example, that are at risk of falling are either going to do that in their bathroom, they might not be wearing a shoe, or they're in bed and they just literally fall out of bed. And that's the case in many skilled nursing homes and other facilities. So, you know, have you thought about alternate ways in addition to what you're offering as a solution to kind of have the breadth of coverage you're going to need in order to save you know, patients from falling, et cetera? And I appreciate the solution you have, but it's much wider than having the shoe, because most of the falls happen when the patient isn't wearing a shoe.
Sure. So I think we can, with that, you know, having it connected to, you know, to something on the wrist of the patient, because that would, you know, if they're in the bathroom, we can probably integrate that information, you know, with an IoT device that's going to be on the wrist, for instance, and with that they can, you know, or a brace in their, or a necklace that they're wearing. So with that, it can be with them all the time.
Thank you very much. We are out of time. This was team A33 Health Connect, and we are moving on to the next team, which is team A05 eCarebatics. And coming up will be team 04 Cumulative. So team 5 eCarebatics, please unmute yourselves and start whenever you're ready.
Hey guys, can you guys hear me?
Yes.
Okay, I'm going to start. Hi, my name is Bing, and I'm here to represent eCarebatics. Next, please. Diabetic retinopathy is caused by high blood sugar damaging the blood vessel in retina, which causes swelling and leakage. DR creates sight loss, which is permanent. Currently, there is 140 million has DR globally, and they are lacking the accessibility for screening. Next. So our initial market is focusing on China. China has over 140 million diabetic patients, with over 37 million diagnosed with DR already, and 12 million of them is losing vision as we're speaking. But there are only 32,000 eye doctors across the whole China, with only 800 specialists with focus on DR. So China needs our help for screening DR. Next, please. The solution to the problem is eCarebatics, which is us, which is combination of mobile app with deep learning model and the DIY link. Once you upload the fundus image, the model comes with a recommendation about the risk of DR. We used 110,000 images from more than 17 public sources to come up with proof of concept. Our methodology is different as compared with any existing AI solution as of today. It is an end-to-end solution using advanced algorithm like customized game version, and we are planning to file a patent next. And here is how to use our app. You can sign in, take an image, and upload for assessment, and then you will get an evaluation with a recommendation. Next. And we got codes from lens manufacturers in China, which we can reduce the cost to estimate about $10. Next. And our value proposition is to create this cheaper diagnostic solution with quick feedback that you can do it at home. And it is always available, so you don't have to go to see doctors over and over again. With our solution, we help the patient to catch DR early, which prevents 90% of the DR progression. And then we can treat it early, which reduces over 94% of the risk of getting blindness. Next. Why us? And this is why our solution is better than any of the existing solution. Next. And our business model, our app is free, and the revenue stream comes from the sales of lens. And we offer one-time payment, but financing is available. Our key partners are healthcare providers like hospitals and pharmacies and lens manufacturers. Our distribution channel are through doctors and pharmacists. Our costs are upfront app development, lens production, distribution, and commission to our sales partners. Our key activities are app development and maintenance and sell to the healthcare system. And our resources are over 110,000 images for analysis with advanced algorithm. Next. And here is our team, mixed with expert in AI and healthcare. And we are committed to eCarebatics. Next. And here is the app index for further information. Thank you.
Team, this is just one question. You said there were 32,000 doctors in China. I think you meant 32,000 ophthalmologists, correct? Not doctors.
Oh, 30, yeah, 32,000 of eye doctors.
Okay, great.
All right.
Thank you. So now, team 5, e-Carebatics, let's move on to the judges' questions.
Great presentation, definitely from the AI community and what's been FDA approved or what they're really interested in. This type of product has already received some FDA approval. So a couple of questions on that, which is how do you compare with existing competitors? It's brand new, right? So FDA hasn't approved that many of these. Also, whenever you're developing AI, you want to think about existing databases that you could start the model build on versus building a model on brand new data. So images are a great way. Like there should be a lot of images of this that you can go ahead and build a model in. If you could just talk about how you're different from the competitors, or maybe it's your market positioning or your intellectual property or your approach towards AI.
Sure. If we can go to slide 8. Oh, wait, slide 8 on mine, but
in the appendix or in the presentation?
In the presentation, with the us. Oh, yeah. Oh, wait. Sorry. Keep going down. Sorry about that. Actually, I'll just explain it myself. So what makes us different is first, we combine, we're not like only AI. We also, so we're like virtual product combining with a physical product. We're selling the lens, like we're selling our product through the lens. So we sell, there's many like AI like analysis for fundus image analysis, but it is all like you have to upload it, and the doctor has to upload it. The doctor has to upload it to the machine, to the computer, and then doctor analysis. It helps doctor analysis. But what we are helping is not doctors. We're helping the individual who has not medical background at all. Like they can screen, like put a phone to their eyes, and then they get the information right away. So they don't have to call the doctors. There are only 32,000 of eye doctors in China, and 37 millions of patients. So that is a huge difference right there. And we're not trying to provide this service to doctors. The doctors still have to receive all that patients, but we're providing this service to the patient and providing them this app. A lot of people has the app, but not a lot of people combining the lens with the app. Combining the lens with the app. I give it.
Bing, let me answer from the ML perspective. So Jennifer, as you raised a good question, what if the quality of images is not good? When it compared to the trained set, the real world data set looks completely different. So even if the resolution of the image is completely low in the real time you have given, so we are using to enhance the resolution of the images using a technique called generative adversarial networks, which will enhance the resolution. How we are doing that? Whatever the data set 110K we have, we are reducing the resolution of all those images and learning the pattern on how the pattern will change from low resolution image to the high resolution image. So it's not only the concept that we are saying, we already built pilot. I mean, if everybody is having time, whoever are interested, we can directly show the demo by inputting the image, how it is transforming the low resolution image to the high resolution image, and how it is predicting.
Kudos to that addresses the major failure in one of the recent trials. That's an interesting perspective.
Thanks, Jennifer. Yeah.
Yeah, another quick question. So how does this fit within medical workflows? So at Google, we developed something similar, and we thought of, do we put it on an app, or do we put it more on a smaller lens device, which can be placed in the doctor's office, or for example, in a local clinic, and that has a doctor that, for example, could then take the next steps with respect to diabetic retinopathy. How does this fit in China within the medical workflow? So if you say, okay, you have diabetic retinopathy, then is this valid? Is this something that then the physician will accept, or how does that work? And who pays for it also?
So let me clarify the question. So first question is who pays for it, or
both who pays for it, and how does this fit within the workflow?
Okay, so first of all, the customers can pay for it, like the patient can pay for it. And we market our product through the doctors. And that's how medical device and pharmaceuticals sells their product, is through the doctors, through the pharmacist. And if the patient go to the doctors and get a checkup, and the doctor said, oh, you're probably gonna need a checkup, but I don't think you can come to here like every while, but I can recommend you to use this device. And then this device is sold to the customers. And this is not an expensive device like what Google is producing. Like in the Western world, productive. Like everything in the Western are expensive, and that is not for the small city, rural areas. Chinese farmers are taking, you know what I mean? Like there are rural areas that has this patient, but they cannot pay $100 and $200, even $400 to get this device. Our solution, $20, that's it. And this can use for 10 years, 5 years. And you go to check up over 10 years, 5 years, that is much more than $20. Go to the doctor. So that's how we, that's why we say like we're cheaper. And that's why we say like we're not helping, actually not helping the doctors, but we're helping the customers, not going to the doctors. And in a way, indirectly, we're helping the doctors as well. So.
I mean, one last point to add is any other products, be it IBM product or the Google product, DeepMind product, everywhere you have some limitations wherein the patient has to go to the respective nearest care and get it tested. Whereas the solution that we are coming up with is like where is the customer, and we are not replacing the doctor, we're just giving the risk score, and it will tell the whether it will comes up with a recommendation wherein you need to meet the doctor immediately based on the assessment. Complete end-to-end solution at the home. If it is a risk, he need to go to the doctor. Yeah.
Hope that answers your question.
Can I ask a question which is sort of related to this? Because I think one pitfall of just having, you know, massive screening, individuals screening themselves, is that that's not really the way medical diagnosis works. I mean, there are all sorts of other inputs rather than just one image of a retina. You know, there's going to be, I mean, so for very rare conditions, you're never going to find them just with one picture. I mean, you need a family history and things like that. I mean, so do you have any way of having other inputs into your, what I assume is a kind of a Bayesian model of what the probability that somebody has, you know, a particular disorder with their eye would be? I mean, there might be a genetic history, things like that would be enormously important.
Chris, I mean, if you go, I mean, one of the slides wherein we mentioned in the clear mobile UI screen, there will be a profile of the customer wherein he will ask a certain questions in terms of filling that. So even that data will be added as an input, like how long you have been diagnosed with the diabetes. So what would be the average H1ABC, the 3 months average you look at that. You want, this is like, there will be a profile page wherein he can update the regular diabetic related stats on the page, and that will be passed as an additional input to the model in terms of assessing the risk.
Yeah, so like,
but I guess maybe that leads to the question, why limit yourself to retinal disorders connected to diabetes? Because there are many other things that you can, problems that you can diagnose looking at the retina.
No, I mean, if you see the Chris, in actually we initially thought of idea with having the whole healthcare related apps under one hood, but then we thought like the issue will deviate. So we started with the diabetic related problems, which is a major concern in terms of the market sizing and the opportunity that we have.
Yeah, I would second that. Diabetic retinopathy is underdiagnosed, a wide problem, and oftentimes it is. I'm not an ophthalmologist, but oftentimes it is more or less just a picture or images. So, and there's also a nice coding related to that in the US. And in the US, at least, not enough patients are screened because the PCP manages the diabetics, and then they had to go take a picture with the ophthalmologist. So that step right there is hard, but it's measured by, I don't know, bundled cares. It's lots of measurements around that.
Thank you. This was Team Fair eCarebatics. For time purposes, we need to move on to another team for cumulative.
Thank you, guys.
Thank you.
Yeah, thank you. So team 4 cumulative, and the next team will be 35 EH row. So team 4 cumulative, please unmute yourself and start whenever you are ready.
Yep, sounds good. I'm just getting situated here. All right, hopefully everyone can see that. Hi, I'm Jacob Fear-Slocum, and this is where computer vision meets telehealth. In the last 8 months, we've witnessed a sudden adoption of telehealth. However, over telehealth, the quality of care is decreased because there's no opportunity for physical examination. We are solving for the physiology gap. Our functioning prototype today is a computer vision algorithm trained on the largest known data set using our proprietary state-of-the-art deep learning techniques. Our model estimates BMI far more accurately than existing solutions for US adults ages 18 to 75. With this, we've been conscious of how our model performs in underrepresented groups from the start of our research. Through a scalable, elastic, cloud computing framework which integrates with existing telehealth platforms, our tech will be ready for millions to use. COVID-19 broke down adoption barriers to telehealth, both providers and patients. But even before COVID, we had the need for more cost-effective care, and we now have the technologies and mindset for telehealth to deliver. But why BMI? After all, it is a flawed metric. Despite its flaws, BMI is calculated each time you go to the doctor, and it is a common indicator of overall health. It is closely linked to conditions like heart disease, stroke, and diabetes. Importantly, it is a chronic indicator rather than acute. Should our algorithm compute an error, no one will be unnecessarily rushed to an emergency department. This is a much safer place to initiate the use of computer vision in telehealth and still add huge value. Where do we add value? Well, 42% of Americans are obese, and it goes underdiagnosed. So this matters for all stakeholders. Patients will experience better care with less hassle at no additional cost. Providers will be able to make more diagnoses, leading to additional reimbursement and improvements to provider-patient relationships. And telehealth services will see better customer acquisition and potentially charge higher fees. What happens if you don't have our software? Well, for most telehealth appointments today, the topic is never addressed, despite how critical of an issue obesity is for the patient. If providers do want the information, they rely on inaccurate self-reporting or expensive smart devices, which few households own. Our licensing model is built on 3 fees: implementation, annual fees, and per-use fees, with strong market potential. On the cost side, initial development is labor-intensive, but ongoing operating costs are very low. Today, we have a working prototype, and a Google Cloud deployment supports HIPAA compliance we know we need while scaling with us. Later, we will deliberately add physiological measurements that augment our chronic care focus, and we'll look to acute care as well, such as blood pressure, heart rate, respiratory health, or even high cholesterol and jaundice. With that, I want to let you know that we are seeking clinicians and healthcare professionals interested in telehealth, as well as engineers with experience deploying in serverless compute environments. Please reach out. Do you have any questions?
Okay, thank you. Thank you, team. Let's move to the judges if they have any questions for team 4, cumulative.
Great presentation. I'm just a little confused. Value proposition is about some sort of capability to analyze a face or body and then calculate the BMI, and you're going to roll. Could you just clarify if that's the value proposition? And then you end it with some discussion of telemedicine and you being your own telemedicine platform.
Well, we're not a telemedicine platform.
Okay.
So what we look at is a service as a software model where existing telehealth platforms currently don't have that physical examination. And so you're missing all of that physiological information.
Sure.
Our computer vision algorithm is able to estimate a patient's BMI with just the face. So how you're already conducting a video telehealth appointment, which means that provider now has additional information when they're treating the patient.
Sure. And do you already have a database that you've validated
yeah.
design?
Yep.
So, oh, interesting. Photos of a face and then also BMI reported in this database.
Yep, labeled images.
Yeah, I'm actually a little confused. I'm sorry. Most telemedicine platforms now integrate your information from your EMR, which has the BMI information. So can you explain that a bit? Why would they need this?
Yeah, so part of diagnosis is tracking changes. So when you're looking at an old EMR or where their electronic health record says their data was in the past, you're not doing a new visit. You're repeating information from an old visit. So what we allow is for that information to be in the visit, accurate to today, with no outside interruption of the appointment itself. So this is fully integrated into the service with accurate information.
And you would want this info. Oh, go ahead. Maybe there's another judge. I'm still a little confused about the adoption by physicians of this, but I'll let other judges ask questions.
Well, if I can actually respond to that, the goal is actually not to sell this directly to physicians. It's to sell it through telehealth service platforms as a small add-on feature in order to boost what the telehealth service platform can show that it can do for providers. There's possibly some scenarios where providers may be able to bill additional amounts for higher severity appointments because of the fact they have real data operate now. But it's about driving customer adoption. It's about getting all the providers to go to the platform that has the best services. And those services will include things like physiology.
I would say that if I wanted to monitor my own health, I wouldn't care about BMI because I can just stand on a scale to get the BMI. It's just a ratio of the height to weight, basically. What I really want to know is either percent body fat or even better than that, how much visceral body fat I have, because those are really the correlates with health. So I'm wondering if BMI is really what you want to be saying here.
It is. And so what you're describing are metrics that are better than BMI, right? But BMI is actually pretty heavily entrenched in the medical community. It's the first order data point that we look at for obesity, and it's closely linked with many conditions. And to tell a little story to your first point about monitoring your own weight, we were testing this on my father-in-law, and they gave us a number back, and we were thinking, okay, it looks like he's about 198 pounds based on the BMI that we're reading. So we asked him what his actual weight was, and he said it was between 170 and 190, which worried us for two reasons. One was, wow, our model might be off. Two was he doesn't know his weight within 20 pounds. He wasn't going to lie to us. He just didn't know it. Turns out his actual weight was around 200 pounds, and we were pretty darn close. So not every patient actually knows the answer to the question of what is your weight.
Yeah, but now nowadays you have scales that are connected, and not only are they just connected, but also you have companies like Livongo, right, that are now part of Teladoc, and you have companies like Amwell that's connected with Google. They're already tracking weight and BMI using, again, scales and other such things for patients where it matters, right? So for obesity, diabetes, and heart failure and others. So how do you compete with that?
This is how we compete with it. Those require devices that you have to send through the mail. And each device is an additional cost to a system, and it requires onboarding. But everyone has a smartphone. Well, not everyone, but about 80% of US adults, which is far more than who has connected devices in order to monitor other aspects of their health. So if we're looking for large scale deployment, unlike a Livongo that's targeting only a specific type of care with diabetes, we need to have something that scales the whole population. And really the only device that we see in every single home is a smartphone. It's more common than really anything else that we can point to.
Your compliance will also be much higher when you have a physician-led ask to do this, right, versus stepping on a scale. That I think is a particularly interesting bent on this.
Yeah, I think the fact it's in the appointment is really important to us. Well, if there's no further questions, I guess the next team can go.
Okay, wonderful.
Thank you.
Yes. So thank you. This was team 4 cumulative. Next team is 35 EH roll. Do judges need a second to finalize cumulative? Let's now move to team A35 EH roll.
Okay, I am here. Hi everyone, my name is, okay.
And upcoming will be 46 freedom. So now
hi everyone.
35 each roll. Yeah, sorry, go ahead.
Sorry. My name is Anthony Trigoso. Okay, next please. Come with us to the Peruvian Andes and meet Maria. When her daughter gets sick, she has to carry her and walk 2 hours to reach the nearest outpost. Moreover, after 1 hour of waiting to be attended to, she finally returns home with some medicines, but without the proper follow-up. On the other hand, next please. On the other hand, we have Peter, an overwhelmed doctor that cares for over 1,000 people in his rural community. He cannot find his patient's profile because of the mountains of paper. Also, he fills up patients' information manually in different forms, duplicating his work. Next, please. Presenting EH Rural. It is an integrated cloud-based system that helps doctors and patients to enhance communication between and remote assistance by providing an electronic health record that digitizes clinical information and allows rural access. Next, please. With EH Rural, doctors could monitor patients at point of care, having predictive dashboards. Also, patients now can schedule visits using a chatbot with predefined questions based on artificial intelligence that doesn't need internet. And the best part is here that we can reach this by SMS and voice calls. The next, please. I think is the, no. One more, please. Yeah.
This one? This one?
No, yeah, that's okay. In Latam, there are several applications about electronic health records, telemedicine, and chatbots, but none of them have a real focus on vulnerable populations in rural areas. In the same way, in Peru, the first time one healthcare startup got a contract with health minister, but having doctors calling patients remotely, but not in an automated way. The next, please. Our business model consists to get partnership contracts, first with NGOs, the government, an annual subscription plan for doctors at private practices, and other stakeholders such as pharmaceutical and insurance companies. Next, please. Artificial intelligence has the ability to save lives, hospital hours, and government funds. It is an intervention needed to be developed by the public health to innovate the practice of medicine. The next, please. Our vision is to integrate the solution with digital hospitals. Having developed an electronic health record that enables real-time collaboration across medical workflows, we will promote the uses of wearable and biosensors to self-monitor patients to support the physician's decision-making and healthcare delivery. And finally, generating clinical research and optimizing financial resources. The next, please. Our team is a multidisciplinary team, and we are happy to respond your answers. Thank you.
Yeah, thank you, Anthony. Let's move on to judge's question, and this is team 35, EH Rural.
Great presentation, and glad that you're spending attention on rural healthcare. And I'm not as familiar with rural healthcare in South America. Also, you've touched on a number of really nice pain points that data and artificial intelligence can, help solve. What do you think is the top 2 problems that you're solving with your solution?
Okay, one of the main problems is the workload of the doctors, because they spend over 40% of their time filling up manual information, and if we can help with an electronic device, even a mobile application, and also a desktop for some hospitals, this is going to be an integrative way to improve the communication between the doctor and the patient also.
So I will add something. Hi, this is Miroslav from the team. So as you can see, just behind there's a lot of paper. And I'm right now in the hospital. I'm from Bulgaria, by the way. And now I have a software company that is developing electronic health records and hospital information system, laboratory systems, a lot of software that is that moves the hospitals from the paper to the paperless hospital and the digital hospitals. So the biggest problem that is we're trying to explain you is that the chatbot is something that could support the people in the rural areas. Why? Because as I can see, I can show a lot of pictures that people are staying in front of a hospital or trying to call to the hospital or to the medical center. And because of a lot of work, a lot of papers, no one can respond them. So there are a lot of emergency cases that we can forest, we can step them forest, just move them in front of everyone, or just these cases that could go just behind everyone. So this some kind of triage is the first one. The second one, they with a chatbot with the predefined questions and predefined template answers, the hospitals and the clinics can collaborate with a lot of data. So they, at the end of the day, so they can see that these people were in these emergency cases. These people were not that emergency, or for something that is something usual examination, a normal examination. But there is something else. So if we know this data, we will collect them. We will collect it in the electronic health record. And so the next time when the person just tap an SMS, because many people don't have internet connectivity or even a smartphone in these places. So the chatbot and the artificial intelligence directly will see who is the person that is chatting right now, so they can see the whole history of the patient, and they can say, oh, hi, you were, let's say, Miroslav, how was your therapy in the past? So do you have
team, sorry to interrupt. I think we need to be concise in answers. We are running way behind. Sorry to interrupt, guys.
Yeah,
the passion was there. The passion is here.
Yeah, I completely see your passion, but I think we are really behind. So I just want to be cognizant of rest of the teams. So if we can be very concise in answers and move on.
I'll just one little quick follow on for this team. I love the passion. I love this the problems that you're trying to think about in rural areas, not just in Latin America, but really anywhere around the world. The question that I would have is on adoption. Have you thought through, how this adoption is going to happen? As you pointed out rightly, internet connectivity is an issue. There's a lot of different types of on the ground, in the field types of issues. I would, if you haven't thought through that part on adoption, I would urge you to think about that.
Okay, I could say a little bit that 80% of doctors working on an outpost or hospitals at rural areas have a smartphone. In the case of the patient maybe don't have a smartphone, but owns a simple one. But this simple one is able to receive an SMS message or a voice call. So we can get this universal access to that people.
Thank you.
Okay, thank you. This was team A35EH Rural. The next team is 36 Freedom Algorithm.
Thank you so much.
And you're welcome. And after Freedom, team A24, please get ready. So now team A46 Freedom Algorithm, you can start whenever ready.
Let's not kid ourselves. The pandemic is here to stay, and it will cause a giant global recession. My name is Kerem Bulik, and I'm an honors medical student, and I see our healthcare systems at their limits, with staff on the edge of burnout. Millions of lives have been lost while governments struggle to find solutions to this enormous problem. The ability to locally predict and prepare for pandemic surges will help against the harms caused by COVID-19. To foresee locally, hospital data and public data should be combined. This is a task tailor-fitted for AI. So we combine our clinical expertise with machine learning to create the Freedom algorithm. Next. The Freedom algorithm will be an interpretable machine learning framework. It will find covariant parameters for local COVID spreading clusters. We then use these parameters in a time series prediction model that can predict regional pandemic surges in a time span of 2 weeks. These specific predictions give hospitals the ability to strategize. We help caregivers to prepare, provide, and perform the care we all need during this pandemic. Knowing what to expect is also very beneficial for businesses. Next. With a simple website, clients can open up new possibilities. Next. Our service, with its user-friendly AI, allows anyone to quickly see predictions in their area. The severity of the local surges can be easily identified on the map, thanks to our clean design. Next. As a social enterprise, we can kickstart a project with research and NGO grants. Ramp-up costs will be very low. All we need is enough money for a few programmers and a website. Reciprocal relations with hospitals will give us the necessary data to provide sharper predictions. This positive reinforcement will create a snowball effect, causing explosive growth in our users. This means more useful predictions, better service, and improved preparations. Compared to the competitors, we have a constant stream of local, up-to-date data. We combine large and small data streams to provide meaningful predictions on a city level. Partnership with local businesses opens up a massive long-term subscription-based market. This integrated system provides security for hospitals, businesses, and individuals alike. Next. As I speak, we are in contact with the crisis management team at the Radboud University Medical Center, discussing possible implementation of the Freedom algorithm. Several businesses have expressed their interest in our model as a subscription-based service. These range from restaurants to door-to-door sales companies. Next. Our team is united in one mission: to locally provide better care, more freedom, and certainty at uncertain times. I want to thank all the participants, mentors, and the organizers, and I hope for your support in the continuation of this project. Thank you very much.
Thank you, Kerem and Team 46 Freedom Algorithm. You are right within time limit. Let's move to questions from judges.
Can you say something about what the data inputs would be to develop the algorithm?
So hi, this is Ian. I'll take that question. So the data input, it's a multi-layered data input. Firstly would be public health data, which would be from NGOs and government sources about COVID-19 spread, about other disease spreads. There are diseases which are connected, which is influenza, and there are other respiratory diseases which might be connected. And there's also hospital data where we know what the ICU usage is like, what kind of patients are going there, the age demographics, et cetera, not to go into too much details. These can first be used to train an interpretable machine AI model to see which of these predictors are important. Once we identify predictors, we can actually use them in a time series analysis using LSTMs and GRUs to correlate with the COVID-19 data and then make predictions for this. What we must stress here is that this is, now we are thinking about it for COVID-19, but this is a more generalized thing because diseases are connected with each other. And if we can get these data sets from multiple partners in hospitals, multiple partners who are NGOs in the healthcare space, this is going to be a really powerful method.
I have an additional question, if I could ask. So I think that the impact is really clear in terms of being able to have people get more meaningful insights on what's happening real time and being able to maybe avoid hotspots in their city or in immediate environment. The question I have is regards to data privacy. How are you safeguarding the privacy of the data that you're culling? And agreed that many of this data much of this data might also be public with your partnerships with local health officials, et cetera.
All right, I'll take this one up. Very shortly, all data acquisition will happen in compliance with CIPA in the USA. As for Europe, we have a threefold strategy. First off, anonymity. So all data will be anonymized. There's no need for us to know any names for us to be able to run this algorithm. Secondly, encryption. We can always encrypt all data on both sides, so nobody can get lost. And lastly, in Europe, we use informed consent. So one of our possible partners would be the Radboud Emergency Crisis Response Team for the medical center there. And they always use informed consent for all data gathering. So we've pretty much got that one covered.
Thank you.
Anybody else?
Any other questions?
Okay, we are taking it as a no. Thank you very much, team. This was team 46, A46, Freedom Algorithm. Next team is team. Oh, okay. Go ahead.
We just said thank you. Yeah.
Oh, I
Thank you,
thought it was a
everyone.
Jack speaking. Okay.
No.
So the next team is team A24 BEH. Team 24 BEH, you can start whenever you are ready.
Hi everyone, I'm Akshay Navlakar. So B is used to monitor employee health in real time. Next slide. Our teammate Priscilla was working in an automotive sector where 450 employees, 50 people got infected with COVID-19 and 3 people died. Company had to bear huge manpower and financial loss and now has to operate at reduced workforce. Next slide. And they are not alone. In Q2, due to the rising cases and shutdown, US GDP contracted by 32.9%. So there is an urgent need to manage health outside clinical settings. Next slide. That's where B comes into picture. It's a complete tool set for managing health in non-clinical settings, using just the user's phone and analyzing physiological parameters, providing actionable insights to stakeholders. Next slide. Here is how it works in a workplace. B starts working even before the person leaves his home. At his home, he does his self-assessment and records his cough signal using the microphone on his cell phone, which is processed by our AI engine. Using the phone cameras and AI technology, we derive the heart rate, respiratory rate, and SpO2. These features are processed to calculate the risk score and flag out employee carrying the disease. This helps in reducing the spread of infection at a workplace, making it safer. The HR and admin just gets the risk score of each user and effectively manage organization health and plan for any no-shows to ensure smooth operations. Any high-risk user will be connected by telemedicine for further instructions. Next slide. Our solution provides early warning for COVID-19 by 2 to 3 days as opposed to just temperature checks. It helps in effective planning of work shifts by 15% and a 10% saving on monetary expense. Next slide. To begin with, we are focusing on manufacturing and then expandable to hospitality and oil and gas sectors. Next slide. We launch a MVP using open data sets. By mid-December, we aim to establish collaboration with hospitals for annotated COVID-19 cough, roll out a beta with manufacturing units in California as we have good connects there, and then a commercial launch in mid-March with at least one client with 500 employees. Eventually, by the end of next year, we plan to use this in remote patient monitoring and telehealth after getting the regulatory approvals. Next slide. Given California's market in manufacturing, our SOM is around 0.25 million users. R is a SaaS-based model charging the business per employee per year. Next slide. We do have competition in the space. Our advantage is creating an early warning system that allows HRs to allow manufacturing units to work with minimum disruption. Our technology is easily expandable to cover infectious disease. Next slide. We are seeking for collaborations with hospitals in India and US to get diverse data sets and a 500K investment for building the product and establishing strategies. Next slide. Our team is from diverse background with medical experts, clinical researchers, and marketing experience well fitted to solve the problem. Next slide. Thank you. Any questions?
Can you tell me again what the what's actually going to be monitored is in this early warning system to identify people at risk? You said this is beyond just measuring the temperature, body temperature.
Yeah, so there are 3 inputs to the system. One is the user symptoms and severity. Second is this forced cough inputs. And third, like using the phone's camera, we will use the RPPG technology to derive heart rate, SpO2, and respiratory rate of the user.
And could you comment on how often you're collecting those inputs and any concern around, big brothering of your employer collecting all of this?
Yeah, so basically all the calculations will be done on the edge device. So there will be no data transfer from the edge to the cloud. Only the risk scores like low risk, medium risk, and high risk will be sent to the employer. Rest of the calculations will be done on the edge. The user, depending on the severity in the location, can be asked to done on a daily basis or like bi-weekly basis. So that's completely up to the employer to decide. And basically what we plan to use is a federated learning technique. So individual improvements in the model, only the parameter updates will be sent to the centralized location to improve our general model as well. So in this way, like we take care of the data privacy issue, and no personal information flows through it unless the user decides to share it first.
I think I'll just say a comment in terms of data privacy. I am not entirely convinced, at least with your current presentation, that data privacy will be safeguarded. If you are to establish anything as far as risk factor attribution, you know, for the employer to take action, that privacy will then have to be, you know, the identity of the person basically gets revealed. So I'm not convinced. I mean, I understand that you're thinking about data at the edge and how data is not stored at, you know, or sent. It's just a data that's being transmitted from the edge. But once you've diagnosed these risk factors, or not diagnosed, but attributed these risk factors, the employer absolutely will have to know who that person is. So there's got to be more thought, I think, put into the data privacy model.
For this one, like when the employer know, like for in particularly COVID times, the employer needs to know like who is at risk so as to like prevent his entry to the workplace. So there are many back to work solutions right now doing self-assessment and creating those things. So it has become like a new norm, at least for the risk scores. But what we are preserving is like the like his chronic diseases and other things don't get transferred from the edge device to the user, while maintaining or safeguarding all of those personal information and his medical history.
Yeah, thank you. For time purposes, we need to move on to the next team. This was team 24, BEH, and we are moving on team 27, Ventilator. And you can start when you are ready. Please unmute yourself, team 27, Ventilator.
I just want to make sure that my team.
You are very silent. Can you move closer to the microphone?
Am I audible? Yeah, we're here.
Yeah, much better. Yeah, you can start.
Hello, everyone. We are Team Ventilator. Next, it's estimated that there's a requirement of 960,000 ventilators for all the reported positive cases of COVID. Also, there's a shortage of respiratory therapists. Next, meet Dr. Sandy, a respiratory therapist who's experiencing burnout during the times of pandemic, as she herself manually personalizes ventilator settings for every patient and monitors the hemodynamic stability. Sandy wishes there was a technology that could let her spend more time being a doctor than a monitor. Next. So we are taking ventilators and supercharging them with AI to save lives. We provide easy to integrate AI-based ventilator controller, Ventilator, to assist healthcare professionals in automatically managing ventilator settings by predicting parameters in real time by bridging patient ventilator crosstalk. This will help practitioners like Dr. Sandy become more efficient and reduce the burden. Next, there are about 60,000 fully functional ventilators, which result to a market opportunity of $720 million at $12,000 per unit. Next. This is a business canvas model. Our value proposition is bridging patient ventilator crosstalk and improved functionalities of existing and future ventilators. Our revenue stream is term-based contract subscription and premium models. The estimated ventilator market is $2.99 billion as of 2019 and is set to increase to $12.54 billion by 2027. We plan to take a market share of about 5 to 7% by 2021-2022. Next.
This is our product development timeline. We have built the team and worked on an idea. Next stage is to go for a proof of concept by March 2021 with a prototype in hand and run pilot test. Then we'll file for the FDA approval and raise funds for scaling up. We aim to produce a deliverable product by the end of 2021 or mid 2022. Next. There is no fun without competition. Though there are no direct competitors, we consider Leven and Mermaid Care as our potential competitors. Our product has a USP of being a plug-in and assist universal device that can be used with models having a Wi-Fi or USB connection facility. Next, we can improve the existing versions by adding additional features and launching a version 2.0 of a model, thus saving lives of people, not just in the COVID pandemic, but also after the COVID pandemic, that is in the post-COVID era, by providing good quality ventilators and reducing the burden of many healthcare professionals like Dr. Sandy. Next. The team slide. We have a diverse team. We have Ebube, a software developer, Jatin, a bioengineer, Omar, an electronic engineer, and myself, Dinesh, a clinician. And next, we'd like to thank all the mentors who have helped us develop this. Thank you.
So great presentation, really important need, especially during COVID. The US has really seen the need for remote patient monitoring for ICU. And we've really expanded that use because of COVID. We already kind of had it existing in rural areas where you have an ICU and then you have a pulmonologist telemedicine in. In terms of the application of artificial intelligence, I think everyone's been really brilliant. Could you talk more about the concept of, are you a clinical decision support versus a diagnostic? And then what piece of the ventilator management you're specifically going to start manipulating or doing with the artificial intelligence?
Yeah, I will answer that question. We are not directly manipulating the ventilator. It's actually an add-on device. And this device has 3 different types of inputs. First of all, it got indirect inputs through a pulse oximeter. Then it takes into account also the clinical history of the patient. And then third, it gets information from the ventilator itself through the communication interface. But it does not control anything in the ventilator. The idea is to present an interface to the clinician that will suggest the best parameters given the condition of the patient and the reasons why the machine has taken this decision. So the healthcare professional still have the option to follow his instinct or to follow the advices of the add-on screen. No? It's an assistance device more than a control device for the ventilator. Firstly, because it will be difficult to control directly the parameters of the ventilator because this is targeted to ventilators already deployed in the market. And secondly, because it also is not intended to replace the physician, but to help him.
Great, thanks for the feedback. And you're clearly well thought it out.
Any other questions from our judges? I'm taking it as a no. If no one else has any questions, we can move on to the next team. This was team A27, Ventilator, and the next team will be team A36, Biomasks. Team A36, Biomasks, please unmute yourselves. And you can start presenting whenever you are ready.
Right. Just a second, please. Right, so good evening, everybody. Today we have the pleasure to present you Biomask, a biodegradable option in the middle of a pandemic. Next, please. So let's talk about some facts first. Just in Latin America, it uses more than 500,000 tons of mask a day. And a person who works 5 days a day may generate about a 1 kilogram of mask every 2 weeks. If we take into consideration that they last about 400 years to disintegrate, the problem is obvious and the necessity is urgent. Stay over there, please. Our project, no, go backward, please. Yeah, our project address UN Sustainable Development Goals. As you can see, we cover 7 of them. Our problem is the environmental pollution due to face mask waste. The solution that we came up with, biodegradable face mask. Biomask is made from plant residues. It's polylactic acid made out of corn fibers. It just protects like a surgical mask. Here you can see, oh, sorry. Could you move forward, please? Yeah, our mask, as we said, protects just like we can see in the image of the mask, and its biodegradability it comes from 6 months to 2 years. Finally, its use is from 6 to 9 hours of usage. Next, please. Yeah, right. Here you can see a summary of the new biomass and competitive landscape. We have conventional and biodegradable competitors as shown. As you can see, biomass is equivalent or better when it comes to our competitors, like in cost effectiveness, safetiness, and efficiency. In addition, our masks are also sustainable, biodegradable, and single use. Next, please. We would like to first launch our new biomask product in our home country, Mexico, then expand to Central, North, and South America, and then take our product global. In addition, the global disposable face mask was 74.9 billion in the Q1 of 2020. The price of a conventional disposable face mask is roughly 2 cents of a dollar, and our product will be quite close to that. Next, please. So here's an example of our business model product. In first stage, we will apply to incubator applications, make some partnerships, and make B2C direct to consumer sales. At the second stage, we're looking forward to expedite medical clearance, both in Mexico and the United States. And the final stage, we're looking forward to B2B distribution via medical supply companies that are already in business. Next, please. Finally, our unmet needs are sustainable development, boost the Mexican economy, and entrepreneurship by necessity. And the interest groups that we're aiming to tackle are investors, society, government, suppliers, and partnerships. Next, please. We thank you all, both team, mentors, and judges. Thank you for your time. That will be it.
Thank you, Team 36 Biomasks. Judges, you are welcome to ask questions.
Why is this better? Why is this better than a non-disposable cotton mask?
Sorry about that.
In terms of just thinking about sustainability, what's the advantage of this over non-disposable, washable cotton masks?
Right. The team would like to participate also.
I think it has to do with the difference in the disintegration time. So the amount of time that it takes for a cloth mask is still longer than what our proposed solution is.
But yours is a single use, but if I have a cotton, I have a cotton mask that I wear, same mask every day. I'm a little confused. Just in terms of the overall sustainability.
Mm-hmm. So I think what this is in particular trying to address is the 80% of masks that are on the market currently are disposable masks. And the idea is that it's going to be focused primarily on the consumer, like the actual everyday person, but eventually trying to get clearance so that it can be used in a surgical setting. And in those types of settings, you aren't having reusable masks typically. So that's what the replacement is meant to be. I don't remember the specific figure, but perhaps one of my teammates can mention what it is. But we had researched what the disintegration time was for cloth, and I think it's significantly more.
Yes, In addition to that, we were aiming actually for a protection that is comparable to the surgical masks, and the cloth masks are not always achieving this protection. So that's another improvement.
How are you measuring? I think it's an interesting idea, both the safety profile of it as well as the usability in terms of like what does it feel like on your face compared to a surgical or cotton mask experience?
So it should be somewhat comparable to a surgical mask experience. The idea is that it provides better protection or a higher level of protection just because of the way things are woven together than a cloth mask. And the idea is for phase 2 testing to go and prove efficacy for it so that it can be more equivalent and that it can then be marketed that way.
Interesting, thank you.
Mm-hmm.
I'm glad you talked about the efficacy because that was really my question, which was if you're trying to aim to have this product in use in clinical settings, which I think is marvelous. You know, how do you go about that? And are you in the process of proving efficacy? And is it going to be equivalent to like an N95, et cetera?
No, it will not be equivalent to an N95 respirator. It would be equivalent to a level 2 surgical mask. So what we would do is file a 510K for a class 2 medical device through the FDA. N95 is separate.
Thank you.
Any other quick questions? I'm taking it as a no. This was team 36 Biomass, and we will be moving to the next team, A38 Continental Cure.
You guys.
Team 38, please unmute yourself and you can start when you are ready.
Thank you.
Hello, can you hear me?
Yes.
We're ready. Hi, we are Continental Cure. Next slide, please. Next slide, please. Millions of people suffer from chronic diseases. They require resilience and compliance to balance their disease. Next slide, please. Before crisis, chronic diseases had already led to millions of healthcare costs and facing a patient care avoidance of care of 53%, according with WHO. Next slide. But now, during the COVID pandemic, the problem became even more prevalent. 164 million of people have not sought care that they needed. Even more vulnerable people are choosing not to seek care, even in emergency situations. Unemployment and no health insurance are some of the reasons. Next slide. Our solution is to identify those with chronic disease that are vulnerable, assess their needs, and connect them to their geographic, local, medical, or social support. Next slide, please. In the first step, we aim to collect community and individual data to create a predictive model that assesses geographic repository to identify high-risk patients. Next slide, please.
Based on the community and individual data, we will identify people who are at risk and contact them to check in on their health using an AI-based text and voice virtual agent. In this example, we have identified Anna and have initiated a conversation with her. Anna is recently unemployed, about age 40, and lives in an at-risk neighborhood. Next. These interactions with Anna help us to build a repository of geographic data to help identify people similar to Anna who are at risk. Next. So how are we doing this? We will connect people like Anna to hospitals, urgent care, social services, and other health organizations that can provide the care she needs. Next. We differentiate ourselves by building the missing link between siloed healthcare organizations that are at capacity with patients who need care but have not taken the initiative to seek it. Next. As a result of connecting 168 million patients to healthcare providers, we will see a return to increased revenues for hospitals, decreased government spending on healthcare, and an increase in the number of people receiving the care that they need. Next. We hope you support us in providing healthcare for the invisible patients in this pandemic. Thank you.
Thank you, Team 38, Continental Cure. Let's move on to the judges' questions.
Can you just remind me, I sort of spaced out at the beginning and I didn't catch what are actually the inputs going to be in order to identify people that are at risk?
Yep, so we're going to be using community-based data. If we can go to slide number 165. So community-based data around which one before, sorry. And 163, yeah. So we're going to be using number one, community-based data. So things about what's the population, what's the historical data around populations that have had chronic illnesses, health department data on current illnesses, as well as individual data. So where we will bring the differentiator is we will partner with the Unemployment and Benefits Office to take non-personally identifiable information, as well as tax and revenue offices to take non-identifiable information such as age, gender, income, and things like that. So we will then pair the community and individual data to predict who is most at risk, based on whether they have a chronic illness or not.
And then you will reach out to that individual?
Yes, so we will actually reach out. Yeah, so in slide number 1.64, and we chose text message because it is one of those platforms that everyone seems to be using, and you don't have to create a username or password. And we're going to be using an AI-based virtual nurse to reach out based on the phone number on record for the person in their local government office.
I think because we're focused on vulnerable people, most of people use telephones or cell phones, but we wanted a very simple solution that can be very very inclusive, because normally vulnerable people have low literacy skills, and they also are immigrants, and also you have people with disabilities. So we need to make sure that can reach out to those. So we can do text message or voice or by voice. There's no need to have a app.
Handling patient consent on this, right? In terms of how you can connect to a patient.
So sorry, what's the question?
So how are you asking patients to opt into this, or like providing their consent? Like what sort of?
Yes. When you're doing the immigration office paperwork for an employment, you can have the consent form for that.
Okay, that would be an unusual place to be briefed on a health opt-in.
I mean, if we think, obviously they will receive the text message, but then they're not obliged to respond to the text message. But yeah, it's a good point that you raise.
Yeah, I think it's just worthwhile looking into the, and it's going to vary by country, and actually the UK in particular is amongst the strictest, but how you handle monitoring of patient data and contacting patients would be worth a second look here.
Okay. I agree with those comments.
Thank you. Any other final questions? I take it as a no. This was team 38, Continental Cure. And then the next team is team 1, Biobox. Team 1, Biobox, please unmute yourselves.
I'm unmuted. Can you hear me?
Yes, we can hear you.
Great.
And after Biobox, team 40, Mentio will be coming up.
Okay, I have this little sign, so is it okay if I show this instead of saying next?
Yeah, Igor, can you see her?
Yes.
Okay. Well, is it okay if I share my screen? I think that all the colors and the the thing is kind of ending up kind of weird.
This was probably the second team that we had problem merging.
Yeah. Here, let me just share my screen. Can you enable me to be host, please?
Martina, can you enable that, please?
Yeah.
Can you guys see my screen?
Yes.
Okay, great. can get started. Hi, everyone. We're here because businesses today are facing a crisis in preventing the spread of COVID in the workforce. My friend John, who works for a recuperative care nonprofit, was scared of his employees showing up to work sick and infecting patients and clients. So they were using paper surveys, which were time consuming to process, and their thermal cameras panicked them with a bunch of false reads every day. He wished that there was an easy way to prevent sick staff from showing up and get more accurate alerts on staff that might be infected before they came to work. John's not alone in this issue, and a lot of businesses today are really frustrated with outbreaks that compromise the trust in the safe workplace, and employees are working in fear of being infected. Everyone's struggling and no one is happy. That's why we created Biobox. Unlike other expensive solutions that are biased against low-income, women, people of color, we wanted to provide an affordable, accessible, and equal platform that can give any business early alerts of symptom risks with their staff. Biobox is a home-based AI-powered mobile and biosensor platform that takes digital health outside the hospital into the workplace with a comprehensive system to prevent the spread of COVID by acting like a smoke alarm for infection symptoms. It's made of two components, a text-based chatbot that uses machine learning to accurately collect symptoms and flag anomalies to personalize baseline stats. Our home-based Biobox that's similar to Google Nest or Amazon Echo, packed with time-of-flight infrared sensors to detect temperature, respiration rate, heart rate, pulse oxidation, and infections from coughs. Let's look at how it works. John's staff member, Chris, would simply talk with the chatbot via text before going to work. She gets issued a QR code to check in to her Biobox at home. This logs her readings to her account and detects infections before work. So if she's low risk, she gets cleared for work on the spot. And if her symptoms get flagged, she can talk to a telehealth provider for a second opinion. And when John gets an alert risk, it's only the alert risk, so they can start coordinating for a backup and kicks off a workflow for that approval. So at the end of the day, John feels relieved that Chris feels relieved she didn't infect any coworkers and that her specific health data is private. And John has peace of mind that a potential outbreak was avoided. So with over 70% of employees estimated to be back in the office, we're going after the 110 million employees who are going to be in the workplace. In terms of our business model, we are offering the mobile symptom check as a modular piece for $1.99 a month and $20 for Biobox symptom check as a system. And we have a nonprofit arm that we want to donate this to communities who are most vulnerable. We have IP on RAI on the way we're developing it. We are synthesizing both survey and sensor data, and we have IP on infection alerts that are personalized. Our team has a diverse background in AI and machine learning to successfully bring this to market, and we made this platform to be language agnostic so it can easily scale on a global level. Not only does Biobox help individual workers, it can make a significant impact on families and public health. We'd love for you to join us. Thank you.
Wonderful. Thank you. This is Team 1 Biobox. Judges, do you have any questions?
Yeah, I have a question. I thought that was a really great presentation, but what is the evidence that things like heart rate and blood oxygen, et cetera, are actually predictive of whether you're infected with SARS-CoV-2?
Yeah, so there's two layers. There's one layer that is detecting an infection, and the second layer is detecting COVID specific. So our goal is to gather enough data and train the AI to get to the point where it can identify COVID specific, but the first layer is protecting against infections in the first place. So you're right, there's a distinction between the two.
But even an infection, is heart rate a very good predictor of an infection?
Yeah, there's been recent study released by wearables on heart rate alone being a predictor of infection. So up to 3 days early before symptomatic onset. And then the database surveys from the UK and Europe that they've been doing that are only input, those have been shown to cover 80% of predictions of infections. So our hypothesis is combining the survey data with the biosensor data will lead to an increased prediction ability.
So good presentation. And I think that this is very well thought through in general. Question regarding, you're going after employers then who are going to buy these Bioboxes, if you will. Mm-hmm. And then would the employee be then paying that monthly fee? I mean, albeit it's $1.99, but you know, and I understand you have a nonprofit arm for other populations that may not be able to afford that, but who's basically buying this and how are you getting out the distribution for this?
Yes, so it would be the employer who is buying it and paying for it. So they have budget for setting aside to prevent infection in the workplace. So I work in property technology, rolled out B2B SaaS over $6 billion worth of real estate for private healthcare. And they look at this as number one, a possible amenity for their tenants to bring home to have people even come in their buildings. And number two, they amortize it through their common area maintenance. So it can be carried by the landlord, and also it can be carried by the business who wants to specifically prevent this. So in long-term care, in some places, the insurance is requiring them, if there's one positive test, doesn't matter if it's resident, vendor, or client, they have to test every week for a minimum of 3 weeks until there are 0 positive tests. So businesses get destroyed by this. So if you tell them it's $1.99 or even $20 a month, they'd rather do that than have someone being at the door with a temperature gun and potentially infecting other people.
Got it. Thank you. Really good.
Thank you.
Any other questions from judges?
I was just going to add, school systems would be another one to target as well, with getting kids back to school.
Yeah, the beauty of this is made for families as well. So it's not just one employee. That's why we didn't like the wearables, is just because the science isn't back that it doesn't discriminate. So basically it's not one wearable. You can use this for a whole household. So you have multiple children, you can use this, the parents can use it. So it's a really community and a family thing. And the thing is that all the AI and the sensors, they're POC agnostic and gender agnostic.
Cool.
Wonderful, thank you. This was team 1, Biobox. We are now moving on to the next team. You're welcome. Team 40, Mentio. You can start unmuting yourself. And the next one in the line who should start getting ready is 34, AI plus vaccine.
Martina.
14, Mentio. Yes,
Martina.
I'm waiting for.
Yes, we're here.
Yes, Igor is sharing.
Thank you.
Screen. Yeah.
That's not our slide.
Just a second.
Sure. Okay, that's the one. Can we start?
Yes, you can start.
Okay. Welcome, everyone. I am Gabriela from Mentio. Next. In 2013, I had my first jaw dislocation, but no record was kept in my medical history. 2 years later, I had the same episode, but in a different city, and I couldn't speak and explain to the doctors that it happened before. So I had to wait 2 hours until the specialist could help me. This resulted in a permanent bite problem, years of therapy, and of course, many medical appointments where I have to explain what happened again and again, and a lot of money. But that was only a jaw dislocation, right? So what would happen if a doctor gives the patient the wrong information? The patient could die. So this is why we developed Mentio as a solution to the lack of instant and easy way to keep and access health data. Next. So although there are existing solutions, they only offer time-consuming manual input of health data. But patients want more than just health data management. Let me introduce you to Mentio. Next. So Mentio is a long-term self-health management platform for patients to keep track on their health information on their personal devices and get personalized health recommendations. Patients can manage their health profile by manually text input or voice recording, but they can even upload health files by taking a picture of the file, and our platform, powered by computer vision, will extract the information into the patient's profile. As patients continue to manage their health data into our platform, they will generate a personalized health portrait, which will allow an easy and fast access to critical health data. Based on our personalized health portrait and symptoms tracking, Mentio will generate personalized health advices, continuing risk assessment, and recommend pathways for better health. Next. So chronic disease are the major problem in the United States, and individuals with chronic disease are in need of a better self-management health platform under COVID-19. So without the properly tracking up-to-date symptoms related to COVID and current health symptoms, they are at the increased risk. So our freemium-based model offers a self-management and symptoms tracking capabilities. And our premium paid subscription model offers a health expedition and personal health recommendation. But of course, Mentio is for everyone. Next. So Mentio has been developed by a diverse team with dominant expertise in healthcare, health informatics, engineering, and entrepreneurship. Next. So we are looking for mentorship and partnership to make Mentio into reality. So come join us in our journey to make healthcare easier. Thank you.
Thank you, Gabriela and Team 40 Mentio. Judges, what are your questions?
Coming back to the original example, which I guess is this event that happened to you, would this actually help in such a case? I mean, wouldn't it require that the city that you were visiting actually necessarily have the appropriate software to get access to your medical records through your cell phone?
No, like they wouldn't need it because I can show it for them. Like our app will have like an easy way to get into like my principal info health. So they can just see that that happened to me before and I will show them. They don't need to get into a system because I will be carrying it with me.
Great presentation. You definitely nailed a lot of pain points, including the portability of the EHR. And there's a lot of interest in managing chronic diseases in the United States and doing that well, and also combining some support services with like touch points for the patients, and some software enabled services. If you were to pick one or two chronic diseases that you could focus in on, what are the top ones that you think this would work with?
I'm gonna take a shot in the question.
Sure.
Would be those top the two top C's, the cancers and cardiac or even diabetes patients, because they a lot of time when you have cancers, cardiac conditions, or diabetics patients, you are gonna have multiple chronic health conditions, and it's really difficult for those individuals to keep track of all their information under one platforms. Commonly right now, they're probably gonna have a binders of information to carry from one physician to another physician. So with this, as long as they're able to like upload all the information into the applications, they're able to keep track of everything under one go. So if they need anything, they can just pull it from one application instead of going through the binders they currently have.
Yeah, no, I think that's definitely great. And, definitely something that a clinician thinks about a lot, which is how to convince their patient to keep information, keep track of it. What would motivate the patient, or how would that work?
So to motivate a patient right now, that's the struggle right now with them, is they have to retrack all the information from their memory right now. Majority of the time, they actually don't carry binders, but if they do, that's what they have to do. And that with a major motivation. At the same time, with cardiac diabetic patients, they have to keep track of daily symptoms such as heart rate, glucose levels. So in order to for them to better manage their health, our platform able to flag if they are in increased risk to having arrhythmias or cardiac attack, or even diabetes attack. So we can flag them to see immediate consultations from physician right away. So that would be one of the major motivation for them to join our platforms.
Usually the patients keep those data in paper. A chronic patient has like a lot of binders with exams and other prescriptions for another doctors. So he is already doing this. We're helping him to do it better.
Great, thank you.
Thank you.
Observation, and I think somebody had spoken up on this on chat, but since you're really putting the person kind of being the controller of all of their own data, I would urge you to look at blockchain-based solutions for data on not just security and privacy, but also identity.
Okay, great.
Yeah,
Thank you.
yeah, for sure. Like the only, I guess, the downside with blockchain right now is not well adopted, and at the same time, as long as we use blockchain, it could increase the cost, and a lot of time patients. Yeah.
Have a look at my book. It's more widely adopted than you're thinking. So yeah,
Oh,
there's
okay.
more there to it, but not to take up time here.
Okay.
Okay, great. Thank you.
Any other questions? So I think we are out of time, so we should probably move on to the next team.
Thank you.
So this were team 14 and Theo, thank you. The next team is team 34 AI plus vaccine. And the team that should be getting ready next is 48 computational. So team A34, please unmute yourself and start when you are ready.
Okay, AI plus vaccine, personalization of COVID-19 vaccination using artificial intelligence to improve safety, effectiveness, and accessibility. I am Robert Furukawa, professor in industrial mechatronics and bioengineering. Next, the problem is that the problem are vaccines are being developed in an accelerated way, and there are serious cases of lack of studies, such as vulnerable groups, the affection of next generation, example, Zika for microcephalia and the male reproductive organs. There have been cases of failure in previous vaccination protocols that cause people to die. Each laboratory is developing the vaccine based on their previous vaccine experience. However, why not to start the ideal vaccine for the virus, or it is to be done with trial and errors? Errors can cause death. Many interpreters know that it is not a way. We have more than 1 million deaths and 35 million recoveries with post-COVID syndrome. Next. The proposal, next, is to use information from the preclinical and clinical, back, please. Okay. Yes, the proposal is to use information for preclinical and clinical trials of phase 1, 2, and 3 to make the artificial intelligence algorithm that can achieve a match of the safest and most effective vaccine for each person. Conditions such as age, sex, existing disease, affectations of close relative, and each country for accessibility by a platform in the cloud. Next. How we will do it? Next. Okay. We are participating in an independent study of an effective, safe, and accessible vaccine. We have a contact of a doctor that is in charge of evaluating the safety and effectiveness of vaccine in Peru, the CBM Center of Excellence, where they monitor the phase 3 of a clinical trial from Sinopharm, CureVac, Johnson & Johnson, and AstraZeneca. My thesis advisor from the master degree in biochemistry, Dr. Mirko Simic, develops the Peruvian vaccine using recombinant proteins and is in the clinical phase. Next. The market. Next. Okay, the market and loss of profit. Peru has 3 million people. In Latin America, we have 650 million. In the world, we are about 7 billions. The lost profit is about 10% of the GDP. A government month fee, citizen month fee or donation can be suitable. Next. How we will do it? International cooperation. Here at the hackathon, I found 17 teams that complete the project. Next. Why us? We have participating in a research network. We have found about $150,000 from the Peruvian government. Next. And this is the team. Next. And next. Yes. Yes. This is a team, and on the right is my students. Thank you very much.
Thank you. Let's move on to the judges' questions. This is team 34, AI plus vaccine.
Go over your solution again. I kind of want to take a closer look at what exactly the solution is. I mean, I agree that the impact of this is pretty high in terms of trying to develop the solution, but could you go over your solution again?
Yes, the proposal is to use information for the preclinical and clinical trials of the phase 1, 2, and 3 to make artificial intelligence algorithm to achieve a match of the safest and most effective vaccines for each person.
And so you're basically collecting data from the clinical trials in the 4 phases or three to 4 phases towards more personalized vaccine applications, and you're working with the Peruvian government to do this?
Yes, we have a grant funding for pandemic surveillance, big data, and artificial intelligence. Yes, we have already the funds. We will start.
That's great. Thank you.
Okay.
Any other questions? Maybe we don't have any questions. If there are no other questions, we can move on to the next team.
Okay.
This was team 34, AI plus vaccine. The next team in line is team 48, computational. And the team that should be getting ready is 55, web curative. So team 48, computational, please unmute yourself. And you can start when you are ready.
Hi, am I audible?
Yes.
Okay, thank you. Nearly 7 per 1,000 women had unsafe abortions in Africa in 2012 alone. 1.6 million women were treated for abortion-related complications each year. We've narrowed our scope to Northern and Southern Africa simply because out of all the pregnancies that arise, 24% resulted in abortions. Now, Africa has the highest number of abortion-related deaths in any world region. Next, please. Next slide, please. Thank you. So the question is, how can we save 1.6 million women yearly using technology as a tool, a problem worsened by COVID-19? We came up with the solution to solve one aspect of the problem, which is upskilling of medical health practitioners. The solution being, can you please go back to the previous slide? Okay. No, please, next slide. Thank you. The solution being the use of VR and AR as a tool to upskill medical practitioners to conduct abortion services safely with less complications, thus improving access. Now, usually training occurs via video and in different practices. The difference in our solution is as shown in the pyramid. VR provides for more immersive learning instead of just hearing and reading. Ours is seeing and hearing, saying and writing, and doing. Next, please. Our market research has gathered that one of the key players is Microsoft HoloLens, which is not only costly, but hasn't had enough reach in our target areas because of inaffordability. Ours is to limit costs while providing access. Now, the key barriers to implementing this would be access to the internet. If I may use South Africa as a case study, there's currently 1 billion rand budget dedicated towards improving infrastructure in the area by 2021. In Ghana, in countries like Ghana and Rwanda, they've already launched satellites to tackle the issue of access to the internet. Therefore, in the coming years, access to the internet in Africa will not prove to be such a barrier anymore. And because VR and AR is so sophisticated, it allows for offline experience as well if the internet is spotty in some areas. Last slide, please. Next, thank you. The key takeaways here is the measurable impact our solution provides to the millions of vulnerable women and girls in Africa. It is a scalable concept which can start in one area with a group of providers and eventually expand. Lastly, the impact it has in the community by decreasing rates of unsafe procedures, saving lives, and saving on the cost of complications arising from such unsafe abortion. This will be headed by a dedicated team of legal, medical, and engineer professionals who will take this to the market. What we ask is for guidance, particularly in the business sense, on how we can use this VR concept, or better yet, partner with the VR providing companies and make them and reach its intended market. We also ask for someone in the tech industry who can assist with the building of a prototype to provide this service.
Thank you, Nonova. We are running out of time. Yeah, we are already
you.
over time. But thank you. Judges, do you have any questions? And this is 48 computational.
Great presentation, and really appreciate highlighting and focus on women's healthcare, and frankly, a problem that should have been tackled a long time ago. We continue to have so much lack of appropriate focus on women's health care, access to healthcare, appropriate care. So kudos to that. Also agree with the use of VR. A number of the medical diagnostics are focused and working on that. And I just saw Boston Scientific's VR for surgical procedures, where they facilitated the first pacemaker remotely on one of the COVID ships that were floating around the US in the very beginning of COVID. So it's there. COVID's accelerated the use. There's clear indication that now we have technologies that can support surgical needs. There's more discussion around that. What piece do you think is the piece that's most needed? So if we already have the VR, like Boston Scientific has a nice piece, is it the access to the surgeons providing the assistance? Is it on the ground acceptance from the local community to have these surgeons come in? What do you think is the biggest piece for implementation?
I think the biggest would be affordability, because again, as highlighted, we are dealing with low and middle income countries. So you obviously cannot take a VR provider, which will prove to be, too expensive, therefore too inaccessible. So if we can provide this to these surgeons on the ground, but it has to be affordable, because already the healthcare industry in countries like my country in South Africa is already collapsing because they just do not have the money.
Thank you for that.
Thank you.
So
Any other questions?
Yes, great presentation, and I agree with Jennifer. Much needed focus on this topic. So in terms of implementation, and you've highlighted one of the issues being perhaps a cost barrier, what are your thoughts around bridging that gap? I mean, who are you going out to? Are you going out to international organizations, NGOs? Who are you reaching out to make this available and to bridge that cost barrier?
We've decided to narrow it down to NGOs that are already operating in the area in Africa, like for instance, the Mama Network, the Women's Rights Network, Center for Applied Legal Studies. These are people who already have been working on this issue, already have the data, already have the research. So those are the people who need to consult civil societies within the African region. They can give us a go ahead.
Thank you. Anything else? I'm taking it as a no. Thank you. This was team A48, computational. The next team is 55, web curative. And the team that should be getting ready is next is 56, Vaxbox. Yes. So team 55, web curative. You can unmute yourself.
Good afternoon. Yes, thank you. Good afternoon. We are from team 55 want to present in our field. Next problem, 7 million health workers missing globally in rural areas compared with 3 million in urban dwellings. Next, unavailable 63% of the world of rural population don't access healthcare compared with 33% of the urban population. Poor quality of healthcare.
I'm sorry, I can barely hear what you're saying.
Yeah, I'm having a hard time too.
I can hardly hear you.
For quality healthcare, the situation is worse in low and middle income countries. Lack of healthcare workers, an issue that has long been at the forefront of the healthcare industry. Next, solution. First, supporting healthcare on rural areas. 2, improving the quality of healthcare. 3, innovation on the healthcare technology. Next, value population. Next, Medical AI technology not only improve physical efficiency and quality of medical service, but other health workers could also be trained to use this technique to compensate for the lack of physician. There will be improving the availability of healthcare access and medical service quality. Next, business model. We cooperate with government, collaboration with hospital and technology expert people. 3. Partnership with healthcare industry. Next, then this is the preview of our project. We provide some features. There are first online medical AI system. The system will be used in the most basic level of rural healthcare setting. 2. Regional medical AI support center. This could be set up in county hospital and in state or provincial hospital. 3. National medical AI development center. Its role is to coordinate the development, promotion, and upgrade of medical AI system nationwide and to foster international cooperation. Next, working model. Perform programming repertoires free for 2 years. Make the price affordable. Free shipping for the first time purchase. Next, competitive analysis. Next, there is a pet AI way ahead in Leipzig, Vietnam. Next, feasibility reality. First, planning making provide solutions to problems that are expected to be helpful for patients. Material making, the store consists of AI and material for the tools. 3. Research and improvement to make better result and maximize the function of AI technology. Finish project, product, and marketing. Then the implementation of tool in healthcare, namely the application of product will be used by patient. Thank you for the attention. I'm apologies if there is a mistake.
Yeah, thank you. Thank you. Judges, do you have any questions? This is team 55, web curative.
Sorry, I really couldn't understand a lot of the presentation. I think the audio wasn't very good. I can see that it is something related to AI and rural applications. But beyond that, I didn't really understand much about how the model works. So I apologize that I just didn't hear enough from the audio.
Any other judge? Yeah, I assume it was hard to understand, so it's hard to ask questions if you don't understand that much.
Yeah, my apologies. Two sentences, the value proposition of what you're doing, and how you're doing it. Sorry.
We are doing to connect with AI technologies and government to implement and to balance healthcare tools in rural areas.
Thank you.
The next presentation.
Yes, the last presentation is Vaxbox, team 56. Team 56, you can unmute yourself.
Yeah, thank you. Please, can I get a verification that you can hear me?
Yes, we can hear you.
Okay, thank you. Okay, so the name of the theme is Vaxbox, and we are a social enterprise. Before I begin the presentation, I'd like to share a story. And this story is a personal story. So when I was growing up as a child here in Nigeria, I used to live at a local community in Ondo State, where I'm from. And back then, there used to be this polio vaccine program in my village. And so community health workers would come to the village with boxes of vaccine and go door to door to administer vaccines. This has been the way that vaccine has been administered in Nigeria in local communities. And in a way, this sort of motivated me to think about vaccine delivery and how to optimize the delivery of vaccines, ensuring that patients receive safe vaccines and even quality of care. Next, please. Looking at the statistics, we see that immunization is important, and about 2 to 3 million deaths are being prevented due to immunization and vaccine. I probably wouldn't be alive today if I was not immunized of polio vaccine. Next, please. Cases of wild polio have decreased have decreased by over 99%. And today, Nigeria is even polio free. Next, please. With the new COVID-19 virus pandemic, I try to imagine a world where everyone is immunized against COVID-19. But I'd like you to also imagine with me, imagine a solution that is scalable in vaccine delivery and administration. This is possible, but I realize that there are some bottlenecks related to logistic management information and health management information system. The WHO and UNICEF stated in their policy statement, joint policy statement on vaccine supply chain, that less than a third of low and middle income countries have proper information system. And using Nigeria as a case study, Nigeria is the largest population in Africa. And as predicted by Forbes statistics, Nigeria has a growing population that is likely going to be the third most populous country by the year 2050. How do we scale up vaccination? How do we build up resilient system in a post-COVID era, during and also post-COVID era? An article published by Temileyin Omole using Nigeria as a case study, we realized that some challenges, some logistic related challenges involves cold chain and vaccine integrity.
Thank you very much. We are over the routine, over the length of the presentation. Judges, do you have any questions?
Maybe I'll let you finish just explaining what the value proposition of what you're proposing is in a nutshell.
Thank you. Please, can you go to the slide that highlighted the business model? Thank you. Yes, thank you. So the value we are offering as a social enterprise is to provide a web-based vaccine delivery optimization where we have a blockchain AI technology that helps to manage the logistic related data. And we have a cloud storage that helps optimize the health information data. We intend to work with suppliers, for example, government, NGOs, farmers, and donors, and agents. The agent we want to work with are healthcare providers at community level, which includes community pharmacy, primary health centers, and clinic. And we also want to work with patients. And this web-based model allows patients to register online, register with an agent online at the community level, and this agent registers with a supplier, a vaccine supplier. And the vaccine supplier, that's the warehouse or government, register on our database. And we have a product. Can you, next slide, please? Next, please. Yeah, we have a product called Box A. Box A is a passive vaccine storage device. So this vaccine storage device helps suppliers to transport vaccines from their warehouses to the agents, to the health service delivery centers. Because from the data that we got from the research data, there are a lot of bottlenecks with the transportation chain.
Thank you, Sylvester. I will really need to cut you short because we want to be fair towards other teams who had time limit. So let's move on to the questions from the judges based on what was presented.
Thank you.
Yeah, thank you.
Yeah, I think I'm still struggling because the presentation was sort of choppy on this due to time constraints, perhaps, on what exactly, and I'm curious about the blockchain plus AI portion, obviously. This is a problem that is important in terms of worldwide distribution of vaccines, and last mile delivery seems like a very good problem to solve, but not very clear in terms of the solution, how you're doing this and how you're working with the other agents to ensure this.
Yeah, thank you very much for bringing that up. So I'll specify on how the blockchain AI works. So we have a blockchain AI technology where the suppliers are connected to the blockchain. The agents are also connected to the blockchain. So I use a community pharmacy, for example. So a farmer, like a supplier, supplies the community pharmacy some vials of vaccines, and then the community pharmacy uploads the stock received into the block, which goes directly into the blockchain. And on the blockchain, we are able to monitor the stock level, and through this stock level, the supplier, who's the person who supplies to the community pharmacy, is able to realize, oh, this agent is running out of stock, is low on stock. We should I should call.
Hi, I think we
Hello? Oh.
We lost audio.
Sylvester, we cannot hear you.
The vaccine most and helps the agent as well to know which supplier has stock available. The blockchain technology also would help with pricing of vaccines, because we have competitive supplier database data available, so the agent can select which supplier offers the best, the most cost-effective vaccines at that time. So the blockchain AI platform is more or less an interaction, a logistic interaction between the supplier and the agent. It also helps with making payment, making sure that payments are transparent and are also like they are transparent. Yeah, thank you.
Thank you.
Okay. Yeah, thank you. This was the last theme. Can we switch to the next slide? Thank you for all our wonderful sponsors who joined this event. We are very grateful to have you present. Next slide. Congratulations. This was the last team presenting, and we will be having award ceremony. There is a little bit delay when compared to the initial schedule. We expect that it will happen at 7 p.m. Igor, did you want to
It will actually be, at this point, it will be 7:15. So because the judge deliberations for this track will start now, and we need an hour, so it'll start at 7:15.
Okay, good to know. Thank you. Thank you, everyone.
Judges will take a few minutes break. I have updated invite to 6:15. So
thank you very much. Great job,
Wonderful.
everyone. And Thank you very much.
Thank you. You did it.
Well done, everybody.
Everyone
Thank
should
you.
be, regardless
Thank you so
regardless of the award results, please, everyone should be very proud of their work. Congratulations.
Absolutely.
Thank you, everyone.
Thank you. Thank you to the participants and the judges and the mentors. Thank you very much.
We thank you.
Definitely.
Thank you so much.